I would like to start by thanking the organizers of this webinar, Ophthalmological Society of Nigeria and our own Glaucoma Society of Nigeria, for giving me an opportunity to participate in this webinar. Actually, my presentation has been made easier by the first two speakers that have said all I want to say. So, but I have no financial interest in any content of my presentation. And this has already been said in the introductions by other people. But what I would like to add here is that in a patient with glaucoma, especially in the presence of advanced disease, small cataract can disproportionately affect their vision. So you can have somebody with grade 1 cataract by vision markedly affected. Now, if you have a patient with glaucoma, the first thing you would like to do is to find out how much of the visual impairment is contributed by cataract. This is one of the patients. As you can see here, this is cataract about grade 2, and this one is grade 1. The vision in this eye is about 160, that's a counting finger at 1 meter, and this is about 624. Now, looking at the cataract and the amount of visual loss, you know that in patients with glaucoma, cataract will disproportionately affect their visions. This has been said already, the different option in a patient that has combined cataract and glaucoma. Is that a different option? You can do cataract surgery alone, or combine cataract and glaucoma surgery, or you can do two-stage procedures. Now, each one has its advantage and disadvantage. For example, if you are doing cataract surgery alone, and these are the indication, increased preoperative IOP, and narrow angles, and then older patients, and somebody that has no significant visual field loss or optic nerve head cupping, or somebody whose IOP is controlled or less than 2 anti-glaucoma medication. And this is a patient that I want to share with you. She came during this period of lockdown. She had injury, airbag injury, during this COVID period. She's a 35-year-old female, presented with loss of her vision was HM, and she had grade 1 cataract, and IOP was about 58 millimeter of mercury. And when she presented, she was on 4 anti-glaucoma medications. Now, what I did was to do cataract surgery alone. And this is the results a week after surgery. The vision improved, the IOP dropped, and she's currently on 1 fixed drug combination, that is MISOP. So now what's the advantage of this approach? It restores vision promptly. It's a single procedure. It's technically easiest, like just cataract surgery that you have done, and it facilitates post-operative evaluation of the discs. However, it has a disadvantage, like there might be some early post-operative IOP elevation, and when you compare with combined surgery, they have reduced long-term IOP control. And then when you are going to do cataract surgery, glaucoma surgery later, especially trabeculectomy, when conjunctiva is violated, the success of the blade is highly threatened. Now, what about combined surgery? These are some of the indications. Somebody only eye patient, somebody who is, even if the IOP is controlled by the patient is on more than 2 anti-glaucoma medication, or somebody has significant cupping or visual field loss, or somebody cannot use medication. In our own setting, the commonest reason people are not using medication is finance. The anti-glaucoma medications are very costly, about 10,000 naira if you are going to use 2-3 anti-glaucoma drugs to control IOP, or somebody who is younger. Now, this is a patient that I want to share with you also. The patient had surgery just before the COVID. It's a 62-year-old man who presented with, he had visual acuity of hand movement in the right eye. Left eye, it was 660. He had early cataract grade 1 in both eyes. IOP were 27 millimeter of mercury, or 30 millimeter of mercury in the left eye. And the patient is on 3 anti-glaucoma medications. So we made diagnosis of bilateral advanced glaucoma. Actually, in this eye that had HM, the cupping is about 0.95 or so. So what I did was to do combined glaucoma and cataract surgery for him. As you can see, this is the eye about 3 months after the surgery. You can see how the eye is looking, and this is nice forming blade. And this vision had improved from 636 to 612, and IOP had reduced. The time we saw him, glaucoma medication in this eye. Now, when you combine cataract, it has some advantage. For example, it's a single procedure. You do everything at one sitting. You don't have to do glaucoma surgery and then come and do cataract surgery later. And it's restore vision promptly, and it decreased the glaucoma medication requirement, like in this case I presented. And then it's some good IOP control. And of course, it has a better IOP control when compared with cataract surgery alone. And there are multiple options that you can do. Like has been said by other speakers, it can be cataract surgery can be combined with MIGS and other form of glaucoma surgeries. But the major disadvantage is that it has increased intraoperative complications. Because you are doing glaucoma surgery, you are doing cataract surgery, each one can have complications during each of the stage, and has a longer surgical time. My time is about 45 minutes to 1 hour. And then it's more intensive post-operative requirements because you have to take care of the bleb. You have to make sure the bleb is functioning. If there is need for needling, you have to do needling. And then sometimes some patients will still need medication after the combined surgery. Now this is like what Dr. Sarah may show. This is one of my cases. This is how I do my combined TRAB-SICS. You can see this is the flap iris. This is the cataract there already. And now this is after the cataract has been removed. Usually the ostium is determined by the size of the PI is determined by the size of the ostium. When the ostium is large, you have to do large PI so that iris will not plug it. And then this is the PI being done. Now, sometimes I leave only one stitch like this and I close. Well, sometimes we can put releasable stitch. These are two releasable stitch that we put that we can remove subsequently later to monitor for the function of the filter. And this after the conjunctival has been closed. You can see a nice blade has been formed on table and the IOL is in the bag. Now in our practice in our hospital now, we do more of combined cataract and glaucoma surgery than trabeculectomy. We do more of TRAB than we will do more of TRAB-SICS than TRAB. If you can see, these are the months of the year, January, February. This is actually the data for 2019. As you can see, in most of the months we do more of combined surgery. Then in 1 month we did 0 TRAB, but we do 10 TRAB-SICS. Because I discovered that patients tend to be happier when they have combined cataract and glaucoma surgery as a result of improvements in their vision. Now, again, cataract surgery can also be combined with other glaucoma surgeries like glaucoma drainage devices, express mini shunts, non-penetrating glaucoma surgery, MIGS, and endocyclophotocoagulation. Now you have the two-stage procedure. You can do glaucoma surgery first, TRAB, followed by cataract surgery, or you can do cataract surgery, followed by glaucoma surgery. Now, this is needed if you want to do two-stage procedure, especially the one that you start with glaucoma surgery and then followed by cataract surgery, is indicated in a situation where you need lowest IOP post-operatively. As it has been said earlier, trabeculectomy alone achieved lower IOP than combined TRAB and trabeculectomy, combined TRAB and cataract surgery, or in typical glaucoma where IOL is not indicated, IOP is immediate threats to vision. So in this kind of case, TRAB can be done. And then now when you are going to do only TRAB, you have to take certain precautions. You know that trabeculectomy alone increases the risk of cataract development by about 75%. In my experience, the commonest cause of visual deteriorations in glaucoma patients after trabeculectomy is cataract. So knowing this and in anticipation of later cataract surgery, it's always good to site your blade filter somewhere spironasal, so that subsequently, if you want to do cataract surgery, you can do it spirotemporally. Now, this is some of the patients that we did. You can see this is the bleb site. This is where the patient had TRAB a long time ago, and now the patient now had cataract surgery here. And this is another one. This is the bleb, and this is the site of the cataract operation. When you are doing cataract surgery in a patient that had previous glaucoma surgery, certain precautions need to be taken. For example, from the time of anesthesia, there shouldn't be any massage because there is bleb already there. If you compress, there is increased risk of hypotony. And then again, during the surgery, already the patient, it has been shown that trabeculectomy itself can cause some decrease in endothelial cells count. So during cataract surgery, judicious use of Bisco, as said by Harry May also. And then when you finish the surgery, it's always good to put a stitch to close the scleral site and also the side port sites. And then it's good to test to see if there's any leakage on the blade. The advantage of this approach is that you can actually use you can actually take advantage of cataract surgery to do some manipulation. For example, during the cataract surgery, one can decide to do blade revision, or you can do blade needling in addition to the cataract surgery. I've done one in some of the patients. So it's best for immediate intraocular pressure control, possibly best for long-term intraocular pressure, and it's opportunity for glaucoma enhancement at the time of cataract surgery. But the major disadvantage is that it's patients that are undergoing two-stage process. It's a long delay. After a patient had trabeculectomy and then develop cataract, it takes a longer time. Patient become miserable because of decrease in his vision. So they become agitated. Cataract surgery, you lose IOP control. And then cataract surgery in the presence of bleb is technically more difficult compared to cataract surgery alone. But how about doing cataract surgery first and then subsequently come and do glaucoma surgery? The major challenge in doing trabeculectomy in a glaucoma, in pseudophakic glaucoma patients are two. One, the state of the conjunctiva. When the conjunctiva is not mobile, the chances of the filter to succeed, to survive is actually slim. Another thing, that if there is any vitreous in the anterior chamber, it can actually go and block the osteum. So the patient can have failure of the trabeculectomy. This thing, she came with cataract in one eye. I didn't show the picture of the other eye. That was not the focus of the discussion. In the other eye, I think this is the left eye. In the right eye, she had cataract and glaucoma. So I did combined surgery for her. In this eye, she had cataract surgery previously. The IOP had persistently been 25 to 30, despite the use of anti-glaucoma. She was offered, and then her vision remained 636, IOP remained 14, and then she was just on fixed drug combinations. And now, generally, when you are talking about cataract surgery in glaucoma patients, there are certain challenges that you are likely to face: small pupil, zonular weakness, floppy iris, crowded anterior chamber, especially in patients that has angle closure glaucoma. Now, this is what I'm thinking about. This patient has about 360-degree synechia. And then sometimes it might be due to prolonged use of miotics, or somebody that has pseudo-exfoliation syndrome. So in this case, sometimes you would like to use something like iris hook, or you can use sphincterectomy, iris hook, synecholysis, viscodialysis, and so many other devices that can be used to enlarge the pupil. But sometimes you can also have a situation like this. This patient came to our hospital with unilateral angle closure. Unilateral angle closure, the IOP was about 27 or so millimeter of mercury, but I was looking quite ordinarily. It could have gone as a normal cataract, but we don't see unilateral angle closure except there are some underlying pathology. So when I saw already, I suspected some zonular dialysis, and then I dilated, and this is what we found. You can see some. So already pre-op, I know this. This is what I'm supposed to. It's actually helped me in planning for the surgery, which the patient had. We removed the lens because the dialysis is more than 180 degrees. The lens was removed and the patient is currently waiting for the FAQ corrections. Now, this is, the ceremony has already demonstrated something like this, but this is how I do my combined cataract and glaucoma surgery. This is MMC. I give subconch MMC 0.1 mil of 0.04 milligram per mil, and it's widely diffusely distributed distributed over the superior parts of the conjunctiva. And then and this is the periotomy being done. And of course, cautery has been. Now this is, I'm washing the MMC. Now this is the plug. Now this is very important because you have to create the channel for the cataract surgery. And this is side port. This is the rhexis. So this is the IOL already inserted. This is the sclerotomy being done by scleral punch. And the PI. Now I use bicreate O for closure of the conjunctiva. And now the surgery is formed. You can see bleb. Bleb has already formed intra-op. This is a phaco trap. So this phaco trap is actually two-side approach. Now this is the side of the phaco. And this is the side of the trap. So lens was already in place. And now the trap is being done. This is replaced suture. This is ostium. The wound is still, and the conjunctiva is closed. Now, in conclusion, cataract and glaucoma commonly coexist in a patient, and the treatment of such patients should be individualized. This is an article I found that gives a comprehensive solution. Thank you.